each section, if you have any questions, feel free to stick your hand up and ask any questions. We will have a call for a notice appointment if you ask if you have questions. And at the very end, if you are you're not quite sure about something, then come down to the front, have a look at the equipment, ask us any questions, have a fiddle with stuff. So yeah, it's kind of more advice from previous students to current students. So yeah, that's also the point of this is when everyone's in year 2, because you haven't really done much clinical stuff at all, everyone worries so much about the OSCE. And actually, I think it's all about confidence, and it's kind of you have to put on a bit of a front when you go in there, and just it's a bit of an acting game, and you just have to be really confident. Try not to be nervous. Between each station, just completely forget about what was before, or whether it went well or not, and just start again and just put on your clinical phase, basically. So you should all know this by now, but first of all, the OSCE consists of 19 stations, and within this 19 stations, 16 stations are active, and then there's 3 rest stations. 5 minutes per station, with a 1-minute warning bell from each station. Within each station, so 4 minutes you'll have a warning bell, you have 1 minute left, which is quite important for history stations and practical stations because it kind of means time to summarise and wrap up the exam and possibly have some questions to ask you. So take note of that 1-minute warning bell. And then between each station there's a 2-minute gap, and there'll be one station that is a double station, that's a long history, that lasts for 12 minutes. So obviously ignore the 1-minute warning bell for the first, does that make sense? Within the long station, you'll have a warning bell that will be continued. You'll get another one later on. So, is that what? Are you all already aware of this? Anyone pick up their hand if they think that's wrong or they can tell otherwise. Okay. So then, these are the potential stations. These are all online on the long list. So they're groups in history taken, anatomy stations, communication skills, practical stations. Don't take it that you'll get 1 of each, exactly, or that you'll get 2 from one section and 5 from the other. It can be a complete mixture. I remember last year I had 2 anatomy stations, 1 living anatomy station. I had 2 skull and also pelvis. So it's not exactly 1 of each. And also just I can see people writing things down. It's all going to be put online, and a lot of the content of what's in these slides, we're not going to read through it all. It's just more, it's going to be put online, and you can refer to it later. So it should just print out afterwards and use them as a resource. Another resources. Have you all heard of the Olive website? The OSCE video. So yeah, and then there's the clinical skills guide, which are also on the web campus. There's an e-learning website, which is, again, these are all online, so you can use the links from these. And this Masterclass book, has everyone heard of Masterclass? This is a book that will not only come in handy in second year, but also 3rd, 4th, 5th years. And there's several Masterclass books, but this is generally the one that everyone gets, the easy guide for final year medical students. Okay, so we're just going to run through them in the order that I put them up in the long list. So we'll start off with history taken. Okay, so you will definitely get a short history station and a long history station. And they're probably 2 of the easy stations that you will get, because you're probably going to know exactly what you need to ask. So you've probably been told this a million times, but the easy points are easy. So go in, there will always be alcohol gel in every station. So wash your hands, introduce yourself. Some people say you have to use your full name. It doesn't really matter. Just introduce yourself. Tell the patient what you're going to be doing and ask them if that's okay. In second year, as you get further along, you won't do this so often, but there is a point for confirming confidentiality. So it might sound a bit awkward when you say it, that this is going to be kept confidential between you and I and the rest of the medical team. But just say it because everyone will be saying it and they expect it. So once you've done that, name, age, and occupation start, and then you go through the main headings that I'm sure you all know. So presenting complaint, history of presenting complaint, then you've got your partner history, family history, social history, drug history.
what you'll get, but it's typically something like a pain history. So you'll probably know Socrates. Whatever the patient says, just genuinely be interested. Don't try and think it through too much. If your friend came to you and said, I've got a sore leg, you would ask certain questions. So be genuinely interested in what the patient is coming to you with, and you will end up asking the right questions. So if you go through that checklist, where is the pain, what makes it better, what makes it worse, what have you tried, is it associated with anything else, all those sorts of things, you will get all the points for the percentage of pain. And if it's not pain, if it's something else, you can use the same similar sort of structure. So if they say they've had vomiting, you ask them, when did it start, how many times have you vomited. It's always good to ask things about the quality of it. So with pain, you ask about character, but if they're vomiting, you could ask like how much, what the colour was, things like that. So you can follow the same sort of structure, you just need to be inquisitive about the thing that they say. And it will be, for second year, like an isolated thing. There won't be many other things that they'll start talking about because they know that you've got a time limit. Once you've talked about the symptom complaint, ask some other questions of things that in the short history, don't labour about other things because that's where it comes into the long history. So just focus on what they're saying. And then in terms of pathological history, there's this mnemonic that maybe some of you know and some people say it's good to use, jam threads. Really, they're all sort of unrelated things that in practice would be quite strange if you asked about them. But if it makes you feel more comfortable knowing a few things are in pathological history, then you can use those sorts of things because typically it will be a chest pain, so ask about previous MIs, strokes and things like that. Diabetes is always a big one, and asthma, because they can have an effect on many different things, so they're good things to ask. Social history, always ask about smoking, drinking and recreational drugs. Drug history, that also, if you ask drug history and then you hadn't asked about high blood pressure and they say they're on a high blood pressure medication, then that can point you in another direction. And always remember to ask for allergies because that's important. And then the only difference between a short history and a long history is that with the long history, and it literally is the only difference, is that you need to do a systemic inquiry. So just follow the same protocol you did for the previous history. And I'd probably say do it after you definitely, if you forget that you're doing a systems inquiry and you get to the end of the history, you can ask it at the end once you've done all the other things. But you could slot it in after you've done present a complaint, issue present a complaint, and then you do a systems review. And you can do it however way you like. You can remember things that you're supposed to ask in whatever order, but how I like to do it, and a lot of people do it, is just if you're sat there looking at the patient, just go from the top right down. So look at them, think about things like headaches, if they have had any change in their vision, then moving down, so sort of like coughs, ask if they've had any chest pain, if they have any shortness of breath, then move down to sort of like GI, bladder, bowel, musculoskeletal things. If you just go down the body and work from the systems, then you would have asked enough questions to get them. And then apparently, we didn't have this when I was talking, you could get a psychiatric history. Now I understand that you did an in-course assessment on parts of the brain and what tests you're testing for different parts of the brain. I haven't heard of anyone ever getting a station like this, but it's probably good to have an idea of how you might tackle it if it were to come up. So I think the most likely scenario is that they'll ask you to do the digit span test from what people have said. It might be a good idea to have a think about common psychiatric illnesses such as depression or panic attacks. And this slide there, so you can have a look at them and kind of get an idea. I mean, I think most people will know sort of signs and symptoms of depression. But if someone comes in and perhaps they are presenting saying they've got low mood, there's certain things that you can ask for, but I think it's very unlikely that you'll get it. What you could get is a digit span test. So the same sort of thing, introduce yourself, name and age, say that you're performing a memory test, ask them if that's okay, and then I'm not sure if you know what the digit span test is, so I won't bother going through it, but perform the test, and then I imagine at the end of the test, they're going to ask you sort of if they can do this, X, Y, Z, which part of the brain would be affected or something like that, so probably a good idea to read it over. saving time. I think that's a good test. That's the one that's in the lecture. I know there are other tests as well, but that one's one of the ones in the lecture. I think is the one.
With the neuropsych history, do you just test just like problem, or would you do something else that you have to do?
I have no idea. I think it's highly unlikely that you get a psych history because you have an entire psychiatric rotation in third year and you will get tested on it in third year. So I think it would be very unlikely, particularly as they don't go into this in that much detail second year, that you would get it. But in terms of, because there's a specific time frame, they would have put, say, a chest pain history and expect you to get the fact that they're also depressed. That wouldn't happen because there's not much. They can't expect you to do that in the time.
It's one of those things that's in the long list, but I've never heard of anyone having it or having it station, so nobody really knows what exactly is in it. So we're just guessing that from a psychiatric history, if you would have someone presenting with panic attacks or depression, you might like to ask some questions because you're not going to ask a psych onset. You're not going to take a someone who's coming in and says they're depressed. So these are the kind of questions you can ask instead, and then you just continue with the normal history. And then the neuropsychiatric station, which again I've never heard of anyone having. I don't think anyone. You don't know of anyone that has this kind of station, but it's there, and they keep putting it there. I think you all had that in-course assessment. And on that, there's several different types of tests, and the only one that's realistically you'll possibly be able to do within the time limit would be the digits bound test. So I think that's what everyone always assumes it will be. So I think if you're just aware of it, it's quite a simple test, it's quite easy to do, then you won't be phased if it does happen to come up. But I wouldn't spend too long worrying about it. You've got 16 other stations.
And also, something else I've got to say, in both the long and the short history, always do ideas, concerns and expectations, because they're not expecting you to get a diagnosis. That's the main point, the thing they're testing you on, is that you can do a basic history and that you have good communication skills. So, if you're struggling with something, if you can't think of the next thing to ask, or you come to the end of it and you've got time left, always ask them, what do you think it might be? Is there anything you're worried that it might be? And what are you hoping that the GP will do for you today? That's like, you'll get marks for that, and I really encourage you to do that, because that's one of the main skills they're examining on, is that you're a good communicator and that you can be patient-centered. So just be nice and you will be fine.
Oh, sorry, one last thing. They have a script, and so if you keep pushing down a route that they don't have anything on the script, you'll get no answer. So just change the subject, go on to something else. If they're not answering your question, it's because they don't know what to say. And there's certain things that they won't say unless you ask them a specific question. Such as, if they're coming with chest pain, do any of your parents have a heart attack, or what's the health? And they won't say it unless you ask the question. So yeah, just be aware that they're absent. So stick with it.
Hi everyone, my name is Sandy here. I'm going to talk to you about the section. So the anatomy station and also the histology station tends to be stations that people are quite worried about most of the time. So I'm just going to go through what the different anatomy stations are, what to expect, what to prepare, and just hopefully instill a bit of confidence in you about the anatomy station. So the four things that might turn up in regards to anatomy and histology are skeletal anatomy, living, organ, and histology. So I'm just going to talk through each of those briefly. So skeletal anatomy, the way the station will work is you'll go in, it'll just be you, and there'll be some sort of bone, so that might be a pelvis, or a femur, or a humerus, or a skull, and then there'll be a few MCQ questions about areas labelled on the bone. So for this, it's important to just have an idea of these bones, have an idea of the main attachment, muscle attachment. There's any foramina of the skull, where muscles attached to the limbs, where major blood vessels are. One thing I would say, which is really important to bear in mind, is that you're not expected to know your anatomy in minute detail. You don't need to know exactly which part of the bone this muscle attaches to. Just have a really basic, gross idea of your muscle attachments. Really basic anatomy, really. Don't get too caught up trying to learn. So this is just an example. You have to know the difference between, for example, a male and a female pelvis. Just look over that, have an idea they might ask you. This is just another diagram showing muscle attachment. You have an idea of the muscle attachment from the pelvis, holes of the pelvis, so you know what passes through the greater and lesser sciatic foramina. This is just a picture of his skull. So have an idea of what passes through the different holes of the skull. I actually got this from my second year OSCE a couple of years ago. I just labelled the holes and then I had to ask what the different holes were and name a couple of things along through them. This is just an example of what passes through the superior orbital fissure. And a nice way to remember that is luscious French cut with naked anticipation respect. And a luscious French cut for you. And those are the things it stands for. I won't talk through them, but we'll put them on the website. Have a look. It's just take it or leave it. It's just sort of nice. So living anatomy. So that's another anatomy station that might be clear. I might have it from my second year OSCE. So the way this works is you go in, you'll have your examiner, and you'll have your patient there, and essentially you'll be asked to point out the main landmarks in the body. You may be asked basic questions on muscle attachment. So just have a vague idea of the different anatomical areas of the body. So for example, when I did it, I got asked for P7 was. I got asked where the anterior to superior iliac spine is. I got asked about the trapezius, where it attaches, and I could draw around it. And I also got asked about the origin and insertion of biceps femoris. So, these are just examples. Just have an idea of the basic anatomy, basic key landmarks, C7, acromion, anterior, superior iliac spine, etc. Oh, and also, remember to wash your hands. It is a station with a patient, so you introduce yourself to the patient. Tell them before you go to touch them, wash your hands. And that's easy enough. This is just an easy example. And practice on your brain. It's really important just to get together, have a feel of each other, have a practice. And also, this brings up a good point, because sometimes people, when I did it, people went into their year 2 OSCE, and they had a person with quite a large BMI, and that phased them a bit. Don't be phased. Everyone has the same anatomy. Just stay calm. It's easy. You know your stuff. And you can also revise this alongside the anatomy of your written exams anyway. So don't spend too much time focusing on the OSCE. Just keep it as part of your revision for the main exams anyway. Organ anatomy, again, it might give you a plastic model of an organ covered in anatomy in year 1 or 2. So it could be the lung, heart, abdomen, reproductive organs. And you tend to get 10 questions asking you to name the labelled areas of these plastic models. So this is just an example. You might get the lungs, have an idea of just the basic anatomy of the lungs and where the vessels are, an idea of the hyla, which lens is 2 lobes, which one is 3. And also the peanut goes down the airway, which bronchus is more likely to go down? And the answer is the right bronchus. So just no things like that. Learn the structure of the heart, that's really important. So just have a good idea of all the little bits of the heart. These are just examples. You know the branches of the aorta, you know where the sulcus terminalis is, the ligaments arteriosus, etc. Just really learn the anatomy of the heart, and then it comes out really painful. This is the picture of the renal tract again. Just have an idea of the basic anatomy around that. When I did it, I actually got the female reproductive system. This is what I got. And just had to label a couple of things like the bladder, uterus, rectum. And I actually got asked whether the uterus was retrograde or not. So that just means that it slips backwards, which is abnormal. So this is not retrograde. It normally sits on top of the bladder from the anterior to that bit. So that's the anatomy station. Histology. So the way histology works is you'll go in, you'll be on your own again, and you'll get a few questions, and like a picture of some histological slide. You just have to answer a few questions on it. Theoretically, it could be from anything you've covered in histology in years 1 and 2. So have a good idea of the main histological slides that you've covered. And you may also get blood films, which will require you to look through a microscope to identify the different blood types. So to learn histology, I thought it was quite difficult to learn. There's quite a lot covered. And a good resource is actually Leeds Histology Guide. And it just goes through the anatomy really simply, really quickly. It's really worth having a look at. And another thing that's worth doing is having a look on YouTube. YouTube has some really good videos on histology slides, and it sums them up really nicely. I've actually did that myself. It's shot their histology video. And it's really nice to sum up some of the histological slides, which will turn out really useful. So this is just an example. You might get a picture like this. You use areas to identify the different follicles. What is the follicle degree? Just an example. That's everything. So good luck. Do you have any questions? No? Yeah? So normally, I don't want to say definitely, but from what I've heard from my year and also from other years, in a histology station you tend to just get the picture of the slide. And I certainly did. I got a picture of follicles in the ovary. But never say never. But more.
I got my year group, which we did second year last year, we got 2 microscopes, and between each station, someone went in and twiddled the thing. So it wasn't massively out of focus, but you just had to, I don't know what they're called, so the main dial, and basically move it up and down. Because yeah, it's slightly adjusted between each person.
There we go. Anything else? Oh yeah. Again, technically it can be any of the organs you covered in years 1 and 2, but these are the ones that tend to turn up. And really, this is all the organs you have covered. Alright. Anything else? Shall? No? Good. Thank you.
And then ask if they smoke, if they've had any caffeine in the morning. Even if they say they have, then you can say, well, that might affect the reading, but obviously I'm going to continue anyway, and we might want to do it again. Check that they haven't got any pain in any arm, and you can ask them which arm they prefer. They'll probably be sat next to a table, and they'll say the one next to the table. But in certain situations, you shouldn't use a particular arm, so they'll say, if you ask them which arm they prefer, then that's a good way of making sure you don't do anything wrong. Then select an appropriate cuff size. I think people in the to the SPIG, but the one we've got today is automatically attached. So if that is the case, then they're quite easy to attach to each other, so don't panic. In terms of selecting the appropriate cuff size, it will almost certainly just be the standard cuff that you need to use, but you need to kind of just signpost it, make sure the examiner knows that you are making sure that it's the correct size that you're using. Make sure that it's fully deflated in case the person before you hasn't fully deflated it, just like under the dial. Make sure the air's out, and then make sure that they haven't got their legs crossed, and that they don't do it with their arm in their lap. They'll probably be sat next to the table, so get them to put their arm on the table. And then go through the process as I'm sure you've been taught to do. And then once you've done, when you're taking the blood pressure, because you're in an OSCE, you'll probably be panicking and think, oh, I can't hear it, and things like that. But if you can't get it and you don't hear it, I mean, sometimes when I had my OSCE, the person doing it was a very thin woman, and she had quite a low blood pressure. And it can be hard to hear, and you might miss it because you might think it's meant to be higher and it might be lower, whatever. But I think the key thing is that don't lie and say, I think it's this. If you haven't heard it, you're not going to fail the OSCE because you didn't get the blood pressure. They just want to see that you know how to take blood pressure. And you'll take blood pressure a million times in the rest of the course, so it's not a problem if you don't get the correct blood pressure. But if you can't do it the first time, say, I'm sorry, I couldn't hear it that time, try again. And if you can't get it a second time, then either the examiner will stop you, or you'll try it the second time. Because they'll use the double stethoscope, so if you lie and say it's a certain thing and they know it's not, then that's obviously a lot worse. So if you can't get it, don't worry about it. Try maximum of twice, and then afterwards the examiner will they'll ask you what the blood pressure was. If you know it, obviously tell them. And then even if it's normal blood pressure, they'll probably say, what would you do if it was X, Y, or Z? So it's a good idea to know what is sort of a hypersensitive, what you're worried about. And then always say that to confirm you don't like to take it again. If appropriate, you might want to do a line standing blood pressure. And then obviously make sure that you thank the patient afterwards and close, because if you're talking to the examiner, you might get confused. But that's basically it. Any questions? Okay, and then hand hygiene is another easy one. Just the basic steps that you go through. You literally just have to go and wash your hands. The taps in the clinical skills centre can sometimes be a bit weird, which can make it a bit more stressful. But just go in, introduce yourself to the examiner, and then turn the taps on. Make sure that you've got the paper towel coming out of the dispenser, so you don't have to be touching anything once you finish. Make sure the water's warm. They're not going to come and check that the water's warm, but obviously it's good practice to make sure it's warm anyway. Wash your hands. Be really obvious about it. You've got ages. Someone will be taking history and you'll be doing washing your hands, so don't worry about rushing through it. Make sure they can see you in doing each stage. Then obviously, once you finish, don't turn the taps with your hands, use your elbows. Make sure you dry your hands thoroughly. When you're rinsing your hands, they say to try and make sure that it runs down rather than the water runs down this way rather than this way, but I think that's a finer point, so don't worry too much about that. Dry your hands and then stand there without touching anything. It doesn't matter if it's a stupid thing, just be obvious. Stand there not touching anything. And then they will ask you questions afterwards. And these are like basically the common questions that you expect to have. So they'll ask you what other ways you can prevent spread infection. So again, a good way is to just think from top to toe. So don't wear a tie, be bare below the elbows, tie your hair back, wear gloves and aprons if it's appropriate, and you can also use alcohol gel rather than fully washing your hands. And then they'll say, they might ask you, what are the main bacterial and viruses found in the hospital? Or they'll say something like, so what are you washing off? And you can literally name any bacteria you can think of. These are kind of the more common ones. that if you just have like 2 or 3 in your head that you say, that you're planning to say, so if they ask you that question, you can just say them. None of them will be wrong. And then they might ask you about medical and surgical interventions that can cause hospital-acquired infections. So just talk about patient contact, people not washing their hands, and then other invasive procedures. And that's it. Questions?
Hello, my name is Julia. First of all, just to reiterate, because we came in late, this presentation and video, all of us speaking, will be on the internet, so don't worry about finishing your notes and taking photos of things. So I'm going to talk about BLS first. So I think basically the main take-home message that I can offer you, because a lot of what I'm going to talk about you should know anyway, or will know anyway, but the main message is that this is a very, very quick station. So don't panic by the fact that it's technically an emergency situation. Don't rush yourself, because you have plenty of time. And you going slower won't hold you back in terms of marks at all, but just allow you to make sure that you're going to accept properly and doing it properly. Because everyone finishes at least at 3-4 minutes sometimes before the end of the station. And you don't want to sat there running through what you may or may not have done properly, so just take your time and be considered. So obviously first off, assessing arrival of danger, shake the patient, check for responsiveness. With this, I think it's probably the biggest station that requires acting. Try and be convincing at least. I mean, I know that the models aren't that realistic, but like, being convincing because it gives a good impression to the examiner, it makes them know that you're taking this seriously. And if you're not supposed to shout help. Open mouth and remove any obstruction, and do the chin hip on the airway. All of this obviously you can come down and try out on the airway after, if you like. And then, so you've done airway, and then on to B, check the breathing. Look at the chest, get right down close to the chest, and make it clear that you're really looking carefully. Obviously, they won't be breathing, but you want to make it look as if you're trying to be realistic. And then the examiner will often tell you yes or no they're breathing, or you might have to ask them. But don't just put your eyes away. If you have to ask them, just say, are they breathing? And that's fine, put your eyes away. And make sure you do that for 10 seconds. If they are breathing, then you just check them in a recovery position, and you're done. But that probably almost certainly won't be the case because this would be a crap station. So if they're not breathing, then you dial for the emergency services, and you've got to read on the vignette on the outside of the station. You've got to make sure you read where you are. So if you're out in the community, then you dial 999. If you're in hospital, then it's 2222. So make sure you read before you go in what the scenario is. And then you go into chest compressions. They'll probably ask you at the end the rate of compressions and the chest, and they'll also probably ask you the depth. So it's a third into the chest wall. You can say 3 to 5 centimeters, but you might be dealing with large BMI person, so that's good. And then the breathy breaths. They do. This is one of the ones things they do need you to be technically correct on. So for example, with blood pressure, you don't necessarily need to get blood pressure right. But with this, they do want to see the chest rising, and they do want to judge it effectively. So make sure you get some practice. And you just continue 32, and then you'll kind of be doing it and looking at the examiner, and it's a bit awkward, and then they're like, okay, you can stop that. But then they ask you when you are able to stop, and they'll want all these 3 answers. And you coming too tired is a valid answer. Some students are nervous to say that one, but it is a valid answer because you need to ultimately account for your own safety as well. The only time that the exception to this rule about going the chest compressions first and then rescue vests is if someone's been drowning, in which case you start with the rescue vests because their lungs are full of water, so they need to carry it. But the other scenario you might get is for choking. Just know a little bit about asphyxia and the things that can cause it, and also things that it might cause, for example, perforation, things like that. They may or may not ask you how to recognise asphyxia because obviously it's on the model. The models that are used on the choking have been known to break sometimes, so if you're busy doing some thrusts in the armholes off, don't worry, just carry on. So first off, you approach them and you ask, well, it's sort of obvious that they're choking. You ask them to cough or choke, and be known. So first off, you do back flaps, and you use this part of your palm and you just whack them between the shoulder blades. And just don't be afraid to get involved with it. If it was a real person, you'd whack them really hard because you're actually trying to get it out of their mouth. So just because it's a model and it's a simulated environment, you've got to act as if it's real. Don't let the examiner know that you know it's not real, because it just makes them think you're appreciating the situation a lot more. And then, yeah, don't just go on with the abdominal thrust. You've got to actually check if they're breathing again. And if their airway is still blocked, then check out the examiner. And then go through on with the abdominal thrusting. And I'm sure you're all going to do this. Just put your hand kind of just loads it, as if you stare and thrust up. And then recheck and just recheck the examiner. They'll get you to stop at this point. They'll probably require you to do it that many times. And then again, you may or may not be required to call your emergency services. You need to know where you are, you need to know what the situation is. So that the number you call depends on where you are. And the examiner will probably ask you if they do lose consciousness, then what to do, you need to prevent CPR. And then also ask you what might happen next. If you've done the thrust, then the answer always needs to be you're sending to hospital, because you can cause damage to them. Hello? Yeah.
I've got a question. If the patient stops breathing and you start CPR, do the rescue breath?
In this situation,
Yeah.
you wouldn't actually do the CPR because it's a different model. But, oh, did they? Sorry about that. Okay, so you do the rescue breaths.
Do you need in real
You know
life?
there is well.
So what's your question, sorry? If you said you want to start CPR?
So we try to do the rescue breath, there is well. So essentially,
Okay, no, yeah, if you start CPR, you do it as normal, not as if they're drowning. You start off with compressions and then you go potentially breath. You might be a bit further, wouldn't you?
Yeah.
I don't know the answer, to be honest.
Check whether they're breathing first though, because the object was dislodged by them falling to the floor and lying flat. So you basically kind of started on the doctor instinct.
So we'll look it up and we'll get back to you. Sorry. Yeah?
So if you have to do CPR, you restrict compressions, or do you do any like airways and breathing?
Always ABC.
So it's still worth checking rhythm, you should see they're not breathing.
No, you need to check they're not breathing. Yeah, always ABC. Yeah?
When you said repeat it 5 times, is that slaps and then bursts, or is it different?
Both of them 5. Pardon? Recovery position, and then you call emergency services after. Yeah, basically, if they're not breathing, you need to give them your own breaths and compressions, and if they are breathing, they should be in a recovery position, and then you have to. And yeah, just kind of keep communicating with the examiner, because whereas it's not a real patient, it's sometimes difficult to know exactly what the emergency services do, so just keep talking to them. Yeah, and then you keep going to half rise, or if you're exhausted, it's the same thing. This is basically kind of like a schematic approach of what I do there, like get through and stuff. Is anyone got any more?
Sorry, can I just, with the resuscitation, I remember in my OSCE last year, loads of people said exactly the same. You have a little, beside the patient, so, well, Annie was laying on the floor, and then there was a table with a telephone on the work surface, so you always have to go to the telephone, and just make a real big point of what you're doing. And then there's this little yellow triangular box on the floor, and it was a facial mask, and because it was there, everyone thinks, oh my goodness, I need to use this. So then you open it up, and it's kind of flipped in, because that's the way it is in a packaged box. And then I spent ages trying to work out how to use it, and then I tried to use it, and the air was just a disaster. And so I just said, okay, normally I would use this, but as I don't know how to use it, I'm going to scrap that and continue. But I managed to deal with the situation, and in my feedback, I still passed the station, and he didn't even mention it. So I think, I don't really know what to say. Maybe use it if you know how to use it. Don't be afraid to just scrap it, because unless you can see the chest rate rising, you won't get the points. So scrap it and just do it mouth to mouth.
The other thing worth noting is that when you call emergency services, you might turn to the examiner and say, I would now call them, but they'll just literally stare at you blankly. There's a telephone in the room, and you actually need to go over to the telephone, and they will watch you dial the numbers and then say, hi, I'm in this position, and this has happened to a patient, and I need this help. So just have a kind of little spiel ready for that, and it's quite easy. You just say, I'm this patient in the hospital, and there's that patient, and they aren't breathing, and I need emergency help. And that'll be sufficient. Cool. Is that okay? So, with the peak flow technique, I mean, this is quite an easy one, and I think you should be pretty honest with yourself if you don't do it well, because you all know how to use it yourself, and I'm sure you've all done it, and you've practiced in your sessions with other people. So basically, when you're describing it to someone else, just literally describe what you do yourself. So you just, the normal thing is just stand up straight, make sure the meter's back to zero, you don't cover the gauge when you're holding it, change the mouthpiece each time. So that part of it should be very, very simple. The bits where people will mess up will be on communication skills and also the questions that surround it. So asking about their understanding of asthma, have they used peak flow before, do they know how to, do they know what it's for, things like that, and just checking it. Just keep asking questions, and the answer probably won't lead you to have to explain anything to them, but it just shows that you're taking an interest in the patient and taking an interest in kind of their welfare, which is ultimately what they want you to show all throughout the second courses. So yeah, check their understanding and explain the importance, and then how to use it. You just, obviously you do it 3 times, take the best reading, and you do it in the morning and whenever they're having trouble breathing. Yeah. Just basically just says hopefully what you already know, but it'll be on the internet anyway, so I won't bore you with the details. You may or may not be asked to plot it on one of these and comment on whether or not the value that they provide is normal or not. So literally, you just like come along the age. I'm sure you know how to read a graph. You flip the age, women have a different set of lines to men, and then you just get their height and you plot it up against peak flow, and it's down here, it's low, it's up here, it's high. So, yeah, it's fine. But just don't panic if you and then in Hay technique, it's a similar kind of message.
So how do you get their height? How do you get their height?
You just ask them.
Will they know it?
Yeah, and you wouldn't be expected to measure their height in the same station. Probably. I'm very surprised.
It's a measure of it's a measure of their it's not a lung function test, but it's basically a way of the patient knowing how good or bad their asthma is. So they'll get a baseline, and then this is a way of them keeping a diary at home, so they know whether their asthma is deteriorating or getting better, so they can bring it back when they have the next appointment, and the doctor can see what changes.
But for example, I think what this means, for example, your baseline lung function test might be very different to mine, and that doesn't mean that you're better than me, it just means that we're different. So if I had a variation of normal, then it would be significant to me, but it might be significant to you, if that makes sense. Okay, yeah, so it's a similar message within Hay technique. Sorry, yeah.
I was just told that it's always, you don't have to be asthmatic to have peak meters, so I think sometimes I'm very asthmatic. So how do you go about that?
COPD.
Just COPD.
Well, I mean, any respiratory, like even sort of pre-asthmatic diagnosis, they might give someone peak flow meter to assess. It assesses how you're doing, but over a long period of time. So, yeah, diagnosis. And progression of disease is COPD. Okay, yeah, so it's a similar message in Hay technique in that you're actually describing what they should do. I think you should all have that nailed down anyway, and you know, you've probably seen other people using Hay, you might have used one yourself, and you've certainly used it in clinical skills centres. I think you should really have that nailed. The difference between good students and average students is around these other questions, and making the patient feel like you're caring for them and making them feel like you're making sure they fully understand what's going on. So you've got to kind of explain to them what you're doing, ask them sort of about their diagnosis, and have they used an inhaler before, have they seen one used before, do they understand? Yeah. Check the medication type and expiry date, that's really important, always. So yeah, you shake the inhaler, remove the cap. I won't go through these because they'll be on the internet, and I think we probably all know the individual steps. But at the end, it's important to check their understanding and to get them to do it for you back. And if you explain it to them wrong, this applies to the people as well, if you explain it wrong, then they'll do it wrong, so you can then correct them and compensate for the points that you might have lost before. So yeah, the keys are just gather a background of what their previous understanding is, explain it to them, and then check their understanding again. Demonstrate to you. Yeah.
Are those two separate stations?
Yeah. They were in my area. Yeah.
It's good to also have an idea about what the difference between the blue and the brown inhaler is. They might not ask it in this, but they could ask it in an explaining station or in this station. Another thing is when you're demonstrating it to them, I know of somebody who used who like put the inhaler in their mouth. Obviously don't do that, but if you do it, obviously make a point of saying, obviously I would now like get an email please but use a different inhaler if you do that, because obviously that's like that.
As a general rule in OSCE is you'll see yourself doing things that are really, really stupid, and they're not things that you'd normally do in practice, and you know that it's not right, but just say to the examiner, I've just cocked up, but like I wouldn't normally do that, and I would normally correct it in this way. And generally, they're going to be quite forgiving. Particularly in secondary OSCE, there's a lot of anxiety, and they're not going to penalise you if you know how to correct the problem that you've made. So just, yeah, identify your problems and deal with them. Cool. Thanks. Oh, sorry.
Sorry, so you don't actually show them how to use the inhaler, just
Show them, but don't like put it in your mouth.
Be like-
Put it in your mouth.
yeah.
Yeah.
You don't press it down.
Yeah. Do all the motions, but just have it like away.
If you want to use it, you can. If you can put something on it, or if there's another end to it or something. But yeah, don't. Yeah. Pick those a lot easier because they've got the transferable ends, so you can do if there's lots of spares or not. It doesn't really matter.
Urine dipstick. This is one that's you probably practiced those times. So again, I'm not going to go through the actual procedure, but there's a lot of. It's a simple station, and everyone practices it over and over again. But there are a lot of things that you can easily miss, such as the questions at the end are really important. And also, there's nobody actually in the station, so you kind of have to speak to an imaginary person or speak to the examiner, whichever. There's no right or wrong thing to do. You can pretend there's a person there, or you can just ask the examiner questions, and kind of talk through exactly what you're doing. So if you say to the examiner, one option is to say, I'd begin by introducing myself and explaining that I was here to test their urine. Or you can say, hello, my name is Lucy Morris and I'm going to test your urine. Is it okay if I just confirm your name and age? Either way, it's fine. And if the examiner's really fussy, they will tell you, oh no, talk to me, or they will change what you're doing. So yeah, confirm the patient's name and date of birth, always, every station, wash your hands, use the alcohol gel. If you actually use this, as soon as you go into the station as you're talking, because everyone tends to squirt out so much gel, and then you're just stuck there with wet, sweaty, nervous hands. So do this as soon as you get in, then allow it time to dry. I think this is something that people often miss out, is explaining to the patient how they actually need to collect the urine. So be really clear. I know it's kind of a bit of an odd thing to talk about, but yeah, just explain it, be explicit to the patient, and if it's, you'll be told if it's a man or a woman, probably on the lanyard outside, or by the name, you can probably tell. So just, yeah, as a female, clean the inner labia in a single downward stroke, or clean the head of the penis or the fourth penis present. And then with a midstream urine, I think a over, do we start and then stop and then collect it in the middle? If you say to them, hold it in one hand, do not contaminate the inside of the cup, begin to urinate, after a few seconds, without stopping the flow, collect the urine in the cup to the fill line. So I think if you just practice saying it over and over again, then it'll be a bit more natural and you won't be nervous about saying it. So yeah, then the procedure of actually testing the urine can be, I remember, especially I get really shaky in hospice, and you're trying to hold a urine bottle and then twist open another bottle and check the dates, and so it's best really to just set yourself up completely, and just remember, do not touch that bottle of urine until you've got gloves on your hand. Otherwise, on your feedback form, it will say like, touch the urine, disgusted, or something like that. So just, so many people's feedback just said, you just touch urine. So make sure you alcohol gel, wash your hands, put those gloves on before you touch the urine. But before you do that, before you put the gloves on, make sure you check the expiry date of the bottle, maybe unscrew the lid, take one out, place it on the tissue. There's usually some towels in there, place it on the tissue, always screw the bottle back up with the lipsticks, and that's before you touch the urine. So you've literally got your area set up, then put your gloves on, then you touch the urine. And first of all, just ask the examiner, because even though you've asked the patient their name in the first place and you've checked that they've collected the midstream urine, it's always safe to just do it again. Once you've got the urine, you just say, okay, I'm just going to check if this is the correct patient, correct date of birth, correct hospital number, and then you say, is this a fresh midstream urine sample? The examiner will be like, yeah, have it. But it's just always good to just go over it again. So first of all, this is one that's again often missed because you're kind of nervous and want to get that stick in there. So just look at it first, hold it in your hands, check the colour of it, cloudiness, and make it quite obvious, but not over obvious. But just be like, okay, look at the colour and look at the cloudiness. Shake it slightly, just can check if it's frothy at all. And then open it, don't stick your nose to it. Yeah, really be like a chemist and wash it towards you. And then you can see if it smells foul. And then stick your dip. That's right, yeah. Dip your stick, that's the one. Dip the stick, completely immerse it. And then always, when you finish, hold it horizontal, and at the same time as kind of holding it horizontally, you need to kind of put the lid back on the urine. Not necessarily, I was always told don't leave the urine open. So, yeah, bit of a technique, so try that. And then, as you read the results, it's always a bit of a question because you have to wait 30 seconds for the first one and so on. Some people say, I would wait 30 seconds, and the examiner's like, yeah, just read it. Or some people actually sit there and go, I am waiting 30 seconds, and they wait 30 seconds. If you've got through the first bit fast enough, you can wait the entire time and gradually do it. But yeah, I mean, you want to get to the questions, so I'd say it's safer to wait the time because then it will come up the actual reading. Most of the time, it's something like glucose in the urine. And then once you've completed it, obviously take your gloves off, put them away, clear the area, don't touch the urine. Say you'll dispose of the urine, I don't think you actually need to. It's going to be for the next person, but say I've disposed of the urine, and then just clear the area with the gloves off. And then you need to say you'll complete the station by recording your findings in the patient's notes. And at that point, the examiner will usually say to you, okay, what did you find? And then that's the point where you need to interpret the results. And okay, I'm not going to read that at all. But this is in the skills book. This is online, and this is just taken from the guidance for the urine analysis. So just know what each of them mean and the potential different causes. So for example, glucose, it indicates diabetes potentially, but it could also indicate stress, Cushing's, post-general anesthesia, and acute pancreatitis. Everyone just immediately goes diabetes, but it's always good if you can give a list of things. And then usually the examiner will ask you a question on what you're going to do next or something like that. Remember, you can't just presume that it's diabetes, you haven't taken any history from the patient. So it's always good to say, to think about the patient first and say, okay, I've taken clinical history and I've looked for any signs and symptoms. So yeah, first of all, you'll record the results. You'll take a full clinical history and to ascertain any signs and symptoms. Does the sample, and then sometimes the examiner will say, well, what will you do next? And then, depending on the results, it infection with blood or nitrites, or exactly, it all depends on what was actually found. Does the sample need sending for MCNS? Would you think about potentially doing some other blood tests, so for glucose, for using each thing? So it's more than likely that it will either be infection or glucose. But just have those, don't just say, oh, okay, I'm going to send it for MCNS, glucose testing, HbA1c, in a panic. Actually apply it to the scenario. But yeah, the questions are really important. You pick up easy points, so go through what the different things mean. So does anyone have any questions for urine analysis? BMI measurement. This is another.
I never know what to say with the actual reading. Like if you say plus or read the. I think it sounds like
say 3 plus. How many? Say the number and then how many plus.
Instead of the reading. Is that?
Yeah.
Yeah. I always find
it's 3 pluses. Say 3 plus. The likelihood it won't be actual urine, so it's either going to have nothing in it. Usually, or they might have put some sugar water in there, so it might have some glucose in it. But there's not going to be a million different things that you'll have to read off. So you'll have enough time and make sure you just have a look, see what it is, and then just say, you can say it's plus. You're not going to lose marks, you just sound more slick if you say something like 3 plus.
Yeah, I was just going to say, I examined a mock exam for 4 years, which is the last time I taught here as well, where urine dip is one of the things you have to do, and everyone's going, glucose is high, and this is high, I think, and it just makes you sound a lot more professional and confident when you say there's 4 plus of glucose or whatever, so just get to hear that. And I'd read it as you go along, so don't wait to the end, you'll probably just be panicking and completely forget what you read. So read it as you go along, okay, glucose is this, nitrates are this, pH is this, and then the examiner knows how you're reading it. So, any more questions? Yep.
A few different things, though, when it comes to actually reading the dictionary, whether we actually follow the timings on the model, because some people say, actually wait, as it says, but then some people just don't bother and just read it off straight away.
I would say, because it obviously depends what's actually in the bottle. So if you're meant to wait 30 seconds and you just say, okay, I'll wait 30 seconds and then you just read it, you're not going to get the result. So say to the examiner, I would wait 30 seconds and then kind of show that you're looking at the clock, okay, I'm going to wait 30 seconds. And if the examiner thinks that's not going to make a difference, they will tell you to move on. So, and I think some of them, I can't even remember what the bottle says, but I think some of them might say that you need to wait a minute or something like that, but I think if you've already got the results, then the examiner will just say, move on, it's fine. So, yeah, I'd say just go and base what the examiner's, the feedback you get from the examiner. Does that make sense?
Yeah, because one thing, the leukocytes, you have to wait 42 minutes.
They won't let you run out of time. The examiner won't let you run out of time.
Okay.
And realistically, there probably won't be leukocytes in boxes because how are they going to get them in there? So, if you spent a long time at the beginning doing washing your hands and stuff, and you'll just say, I will now wait 2 minutes for this reading, they will say to you, that's fine, and then move on to questions. They don't want to run out of time.
Any more questions? Yeah?
What do you think?
Sorry?
Urea and electrolytes.
Oh, sorry, yeah. That's more for...
That's a fair question.
Yeah, there's more for some of these, if it could be hepatic or biliary disease, it's unlikely to be anything like that. Then another way you can measure it is yeah.
Basically, in clinical years, the answer to every question of what investigation you do is using these. So it's just
I think that was just me automatically putting that on there, that's the answer to everything it's going to do. Yeah. Okay, so BMI measurement. This is I think you should all know how to take a BMI. and obtain consent. Patient might deliberately have stuff, or the actor, put loads of stuff in their pockets, just ask them to empty their pockets. Usually beforehand in things like that, they specifically want you to make sure you calibrate the machine beforehand. So they might fiddle with it a bit beforehand, and then if you don't do it, you'll get a really odd reading. So just make sure you check it. It's on there before. And make a real point of showing the examiner how you're positioning the patient. So they're standing face away from the wall, heels to the wall, head so that the external auditory meatus is in a horizontal line with the lateral canthus. So basically, not like that, and not like that, just head, eyes forward, quite simple. And then move the arm of the plate measure so that it touches the head and just read off the back. And always remember it's kilograms and meters squared. I didn't actually have this station, but I'm guessing they will give you a calculator. And then if you have a chart, interpret the BMI and explain the significance to the patient. So as you finish the station, just sort of sit down. Okay, so we just measured and calculated that your BMI is such and such. This is high, normal, low, and explain what it is. So yeah, this is the chart you get, and you plot it, height against weight. And yeah, so you should always know what BMI is, underweight, overweight, etc. The examiner might ask you specifically in the questions at the end, what would the overweight BMI would be, and they might ask you things like, what are the different reasons for a high BMI, so just be aware of the different, be able to give at least 3 different reasons. I think it's a good amount to show that you know what you're talking about. And then the complications of high BMI, you might ever be asked to explain this to the patient. Or it could be that the examiner asks you questions. This will usually be indicated on the lanyard outside of saying something like measure the BMI and explain to the patient. But I think if you don't do it, the examiner might ask you questions. So yeah, otherwise low BMI and then complications as well. So any questions? Okay, subcut injections. Again, this is one that people practice over and over and over again, so it should be one that, in the actual terms of practical skill, most people are fine with the practical skill. It's just the questions and the little things around it, such as using the alcohol gel beforehand. Use it as soon as you get in there, because when you put gloves on, your gloves won't go on unless your hands are dry. Explain what you're about to do. Always check the drug chart. Make sure you ask them allergens. Make a big point of checking for allergens. And if they don't, obviously there's no patient in there. You're talking either to the examiner or just talking through the procedure. Again, same with urine analysis. I think it's always safer to talk through it and say to this patient that's there, okay, I'm going to be talking through the procedure for the sake of the examiner. Is that okay with you? And if the examiner might be like, oh no, don't bother, I just watch you, then that's fine. And also just helps you in your head to make sure you've just gone through every single step. Make a point of checking with the examiner the amount that you've drawn up in your syringe and your drug chart after you've drawn it up. Those are all the little things that give you the points, and check the medication, correct drug, certain expiry date. There will be several different options of needles and several different types of drugs. Just make sure that you pick up the right one. I think we've done this several times. So at the end of the station, always remember to clean your hands and record, basically a sign of what you've done. I don't really think they have any questions that they ask you at this point. Just the procedure. And just ask the patient where they would like to be injected. Sometimes the examiner tends to be the patient, says, okay, I'd like it in my arm. But always just make sure you ask the little questions. Any questions about subcut? So, yeah, examining blood films. This is very similar to the histology station. So, again, I identify and answer questions on a so I should say blood film. It's multiple choice. I had this last year, and I had exactly there were 2 microscopes set up, and I didn't realise that actually there were exactly the same questions for both slides. So then that really puts you off because you think, oh my goodness, I just said yes for that one, but they're completely different. And also be aware that you have two slides to look at, but only 5 minutes. Don't spend too long on one. I remember I just quickly went through the others and just marked whatever, because I didn't have time to actually look down the microscope. So yeah, it's worth doing that, because again, you don't get negative marking. What do you do? You don't get negative marking. And yeah, you need to be able to use a microscope, but it just involves dialing it up or down. They don't adjust it ridiculously, so it should be okay. And then the blood films, they're not going to be really complicated ones, they're going to be quite obvious ones that you've been through before. So these are taken from your lecture slides. So things like iron deficiency, and it will say questions like, can you see a pencil cell? What could this indicate? It will be kind of simple questions. Yeah, so just be aware of the different types of cells that there are. And like if you see a sickled cell, it's going to be sickle cell anemia. So it's just a case of don't doubt what you see, and just they won't be too complicated. And if in doubt, just mark boxes anyway. Any questions about blood films?
With the blood film station, Jeremy, how many questions did it tend to be?
I actually remember, I'm trying to think of mine last year, and you stand outside the station, and sorry, I just say how, because I was a bit surprised about how it was set up. You go in, there's one long table, there's two microscopes, and there's a piece of paper with your, like a clipboard with your name on the mark sheet, and it's a non-manned station, so it's just you in there. And then had, I think it was 2 pieces of paper, and I think actually for mine it might have been true or false. And they had, I think it was like 6 questions for each slide, but they were exactly the same 6 questions. So it was a bit odd, because then I was like, oh my goodness, it's just not true for that one, but they're completely different. Do I false or? And then when you come out of the station, you have to fold up your piece of paper and put it in there's a little post-it box outside. Yeah, so it doesn't really answer your question very much, but I think just being aware of how the station is set up is probably useful. But anything else? Okay, these are all the bitsy ones that are kind of, I think everyone practices the practical skills so much and then forgets about the little ones. So, using a growth chart, does anyone know, I don't remember when we were taught about this, but it's something that was on the long list. Do people know how to plot a growth chart at all? So, yeah, basically a growth chart assesses the growth in a comparison with the general population and against its previous results. So you need to see, does it cross the centiles, and is it below the 3rd or above the 97th, and that kind of warrants investigation. So to actually plot a growth chart, I think you need to first, I don't actually know if anyone's had this station, but do you know if anyone's had this station? Yeah, I think it's, yeah, I've known people in other years that had this station, but not in 2nd year, but just be aware of it just in case. There potentially be several different charts, and obviously you need to use the right chart for the right age. Don't use the one chart for someone who's 16. And on the baby chart, if they're born before 37 weeks, you plot the week of birth with a vertical line, and then the measurements are from this line. So this is kind of their adjusted line. And if they're 38 to 42 weeks, you plot it from the bold EDD, which is estimated delivery. The estimated delivery date? Yeah. So just plot it from the normal line, but below 37 weeks, you just draw a new line and mark it from there. So, and that's for the young child. For the most likely scenario of it coming up at all would be a 5 to 18-year-old child. And for this, you need to know, they'll probably give you the information for the path, well, they will, they have to. the father's height and the mother's height. You add them together and divide them by 2. If it's a boy, you add 7. If it's a girl, you minus 7. And then this result, so to kind of work through an example there, this result becomes their mid-parental height. So you plot that on the 18th year. So, for example, here you'd plot that along here. Oh, yeah, you plot that along the 18th year. And then you look for the nearest centile. And this is your mid-parental centile. And to get the range of the mid-parental centile, you do plus and minus 10. So, for example, if you were here, and it was 165, I can't really read it there. If it's 165, and it's in the 50th centile, plus and minus 10, and you've got your range of 175 and 155. Yeah. And then you plot the values on the 18th, so plot these values on the 18th year, look for the nearest centiles, this is your percentile range. So there's the percentile range or percentile range. I think if you have practice, then it'll be really obvious. And then you just plot the child's height that he is given at the age, and it should be within your percentile range. So yeah, just remember, if your percentile range is therefore, say, I'm just making this up, 25 to 75, then obviously if the child's 11, you just want it to be between, between those 2 lines. So, yeah, so it kind of obviously moves down. I think if you just have a practice, it will just be really easy. And then you just need to be aware of the potential causes of high or low growth or abnormal growth. So the physiological causes, congenital causes, chronic diseases, endocrine, drugs or environmental. I imagine they would ask you those in multiple choice unless there was actually someone in an examiner in the station watching you. But as nobody really has it, so nobody really knows. But yeah, any questions about that? And if you want to practice on the growth charts, if you type into Google UK WHO growth charts, obviously it's adjusted population, so don't find one from like USA or something like that, just get the UK one. So information retrieval, again, this is one that everyone's a bit sceptical about and nobody exactly knows. I don't know anyone who's had this station, but it's worth just throwing over what it could potentially be, or what the rumours are. So I've heard several different things about this, and again, this is information from students to students, so it might not be this. But I've heard from some people that you use the internet, and you use PubMed or Medline or the Cochrane website, not Google. I've heard from some people that they basically ask you to do, you might have had those library sessions years ago, where they basically ask you to find out how many results were on Medline for certain things. So it could be that. And you'll know what I'm talking about. When they ask you how many, it might literally be asking you to do a search, and then you have to kind of fill in the multiple choice about how many there are, just to make sure that you've done it correctly. Or the alternative that I've heard from some people is that there are 2 screens on a computer, because these are electronic OSCEs, and you'll be given a paper, and you have to extract the PICO, which I've since found out is population, intervention, comparison, and an outcome. I think there'll just be multiple choice questions on this is the paper, what's the population, and just be a case of looking at the abstract and being able to work out exactly what's going on. And then the second screen will be to organise the papers by their reliability. So I think, again, this is just something you probably already know, that the most reliable source of systematic reviews, or even meta-analysis are better than that, but systematic reviews, and then randomised controlled trials, cohort studies. So if you had a series of 6 papers, and one was a case control, one was just an expert's opinion, and that's obviously the least reliable, was the most reliable systematic review. So I think it's just something to be aware of. I don't know anyone who's had it, so I don't think I know what to say. But yeah. Any questions about that? So again, another movement disorders, which is probably more likely to come up than information retrieval. Have you all seen the movement disorder library online? Tom nods. Yeah, it's a link from the Olive website. And this will just be multiple choice questions again. You'll see a video and you'll be asked what's present in what the patient has, and then you can be asked, so if it's Parkinson's, for example, what kind of treatment you should give them, and it'll be multiple choice. Some like to be planned, but it could be. Have you had any movement disorders before? No. Okay, this is another. It's on the list, so we can take it in there. But yeah, any questions about that one? Okay, and then ethics. This one, I definitely had this one last year. The ethics video was you sit there with an examiner, and the examiner has a laptop, and you put on the headphones, and you watch a short clip that lasts for about 30 seconds. I remember my clip basically being about an epileptic patient who had come to see the GP, and he had had a fit recently. And he said that he wasn't driving, but as he left, he went and drove off in his car. So it was what do you do? So then you finish watching the clip, and you saw that the last clip was like the GP watching the patient drive now, and then it was left like that, and then you took off the headphones, obviously, and the examiner starts asking you questions. And they have a list of questions that they have to ask you, which is basically things like, so what option does this doctor have? And you have to, it's ethical and legal, so you have to say things such as, the doctor needs to contact the patient and ask whether he's informed the DVLA about his medical condition. You have to tell the patient that if he doesn't stop driving, you're duty bound to tell the DVLA about it. Yeah, so what should they do? What should the doctor do? And then they asked me, and I remember thinking this was really odd, and just panicked at the time. What are the reasons for telling, and what are the reasons for not telling? So you have to think about, so if you're not telling, in retrospect, I kind of thrown into this saying, in retrospect, it's things like maintaining patient confidentiality, and it's the whole thing of when we came to medical school, you have to balance justice and beneficence and non-beneficence. It's just showing that you can sort of weigh up ethical arguments, combined with a bit of legal stuff in there. Does anyone have any questions about that? So yeah, first of all, there's the exploring and explaining. I remember having this station and just thinking, oh, this is a bit odd, do I take history or not? But it's literally a case of you have to ascertain the patient's ideas, concerns and expectations. The patient I had was a diabetic patient whose neighbour had recently had an amputation. He had been told that he was a newly diagnosed diabetic, but his neighbour down the road had recently had some toes amputated, and he was really worried that he would end up like his other patients. So you kind of have to just explore what the patient's worries were, you listen to them, you kind of show that you're interested, you maybe explain a bit about diabetes, but the key thing is you don't ask about the other guy, because you have to maintain confidentiality the entire time. And I think the explaining and exploring stations overlap quite a lot. I don't know if it explicitly says explore, it might be explain and explore. But just know how to, they won't ask you to explain anything that you haven't learned about this year. Basically know how to explain like these conditions in layman's terms. So explaining to someone about hypertension, asthma, TB, HIV, diabetes, Parkinson's, and know what the different treatments are. And if you don't know exactly, you won't fail the station just because you weren't able to give them thorough advice. It's mainly showing that you're able to talk to someone and that you can listen and you can kind of acknowledge what their worries are. Yeah. And then Katie's going to speak about.
Hi guys, my name is Katie. This is the last bit of speaking we're going to. So sensory awareness stations, there are two that can come up. One is for the deaf patient and one is for the blind patient. And they are really deaf and blind, or borderline. So yeah, just be aware of that, and they will have real sensory impairments, which I think about your guys' experiences, but in my year, for the deaf patient, you had to take a brief drug history, so kind of what they were taking, doses, compliance. And with the blind patient, you had to weigh them and then take them to the consultation room to the GP. So that can throw people sometimes because they're thinking, like, is this a BMI station or is this a sensory awareness station? But it's a little bit of both, and there's no reason why you can't do both elements can pass well because you have enough time. I think it's worth remembering that both of these conditions, hearing impairment, visual impairment, both exist on a wide spectrum, so they might be completely deaf or completely blind, or they might be only mildly impaired, and the only way you can find out is by asking, so don't assume anything about how they want to be supported. You have to kind of take it in. So to start with deafness, yeah, bearing in mind that they might use British Sign Language, but you won't be expected to know that. They might just want you to speak a little bit louder than you normally would, or most likely they'll probably be lip readers. So when you're talking to them, there's just a few things you have to be aware of when you know that someone is a lip reader. Obviously, as I said to start with, you need to ask how they like to be communicated with, because they might not lip read, but that seems to be the most, seems to be the most likely scenario. So when you come in, the kind of seating arrangement is very important, and where the light source is. So if you're sitting in front of the window with a light source, then to the patient you'll be in silhouette and they won't be able to see the details of your face very well. So if there's an obvious light source when in the room, the patient should be sitting with their back to the light so the light is on your face. And it might be the case that the patient won't be sat in the right place and you need to ask them to move at the beginning of the station. So don't be afraid to do that if you think that would make it easier for them. You need to make sure your face is unobscured. So in GPs, they're often like looking at the computer for a look at the patient. I think in an OSCE that would be quite unusual, but just make sure you're not, if you're nervous, or like covering your face or putting a pen in your mouth or something like that, because then they won't be able to read your lips as easily. And don't be tempted to speak more slowly or more loudly than normal, because that will change the way your lips move when you speak, so it'll actually make it more difficult for them. If they want you to speak more loudly, they'll ask you. And finally, don't be afraid if they haven't understood you or if you can't understand them, don't be afraid to repeat yourself or to ask them to repeat themselves. I mean, the aim of the station is to optimize communication, so don't be embarrassed to do that. You might have writing paper and pens available, so if you that would help, you can use those to either write down the questions you want to ask or clarify the answers. So in the example of drug history, you might want to write down what they told you and show it to them at the end so they can clarify whether you've understood something. Because obviously with something like a drug history, it's important that you get the details right. So I think that's about it for deafness. Oh, I think if when you come into the room, they're not looking at you, they're looking at the examiner or looking at something else, then you can, it's okay to sort of politely tap them on the shoulder to make sure they are aware that you're talking to them. They can't really use their name, they might not be aware of that. Any questions about deafness? No? Okay. So for visual impairment, as I said, the station that I've heard of coming up the most is the patient will be sitting in the corridor. They want you to take them around the corner to weigh them on a set of weighing scales, and then take them back round into a room to lie down on a couch, and then you can leave, and then you can come back and guide them back to the chair where they're sitting on in the first place. That's what I had. It obviously might be different for you guys. So there's a few skills involved in that, but just purely based on sighted guide. As I said, these actors will all be used to using sighted guide, so that will make it a lot easier for you because it's completely natural for them. But you do need to ask if that's how they like to be supported, because some people would rather just follow you, they can follow you around, or they might have a guide dog. If they have a guide dog, don't look at the guide dog, don't touch the guide dog, don't acknowledge the guide dog, even though they're really cute. Because if they think that you're now in control of the situation and they think you're supporting a blind person, they'll switch off and not be working anymore. So try and approach from the opposite side if possible if they are using a guide dog. If any of you have a deathly fear of dogs, which some people do, you should probably let someone know now because they might be in your station. So when you're approaching someone, again, it's the same as with approaching a deaf person. When you introduce yourself, you should just gently tap them on the arm or shoulder, wherever you feel comfortable, so they know that you're talking to them. We also use their name, possibly you'll probably know it from the net, so you should use their name as well, so they know that you're addressing them. Introduce yourself, explain what you're going to be doing, ask them how they like to be supported. So if they like to use sighted guides, you simply, you can just stand in front of them, like kind of offer, well first you can ask what side they like to be guided on, so some people use their left hand, some people use their right hand. And
then you just stand in front of them and offer your arm, you can take their hand and place it on your arm. So they should place their hand kind of just above your elbow. It's quite a gentle grip, it shouldn't be like squeezing your arm. And when you're walking, you should keep your arms quite close into your body. Don't like kind of really lean them out like this, because the aim is going to be kind of feeling where you're moving before you tell them. So the closer they are into you, then the better. And just let them know before you set off. So say, okay, we're just going to move off now when you're ready. And you can walk really slowly because you have plenty of time. So don't rush because it feels quite uncomfortable for them if you do. And then just take them to wherever you need to be going. So it's nice to say before we're going to turn a corner, just say, okay, we're about to turn to our left, we're about to turn to our right. If you do need to take them to the weighing scales, then you probably ask them to take their shoes off first. When you get to the scales, you can just say, we're in front of the scales now, I'd like to kind of feel forward with your feet and feel where they are. Or they might prefer to stand on the scales first themselves, so they have a sense of how high up they are, so you can stand on them and come back down and they can do the same. But generally we just say they're in front of your feet now, they'll go with themselves. And then once that job's done, they can put their shoes back on. If you want to go back, if you then have to get them to either lie down on the couch or sit back down in the chair, all you do is with the arm that you're guiding with, you put it down in the centre of the seat of the chair, and say, so this is the chair where I'd like you to sit. It's polite to tell them whether it has arms on or not, because you don't want to kind of sit on the arms. And they can just go down your arms where the seat is. If it's a couch or bed, you should show them kind of which end's the head end and which is the foot end, so they know which way to lie down. And once they're seated comfortably, the examiner might then ask you to leave. And whenever you leave a visually impaired person, you must tell them where you're going. And you should tell them what they can expect to happen next. So if it's kind of a GP session, say, I'm leaving now, the GP will be here shortly, and they'll kind of introduce themselves as they come in. If there's anyone else in the room, so the examiner will be in the room, so you should tell them that there's an examiner there as well. And yeah, just kind of give them a sense of what's going to happen. If there's any obstacles that you come across in your way, you can just say, they often put in like lots of tables and chairs in the room so that it's a bit more tricky for you. Don't try and move the furniture, that's not what you want to do. Just say, there's a lot of tables and chairs around, so just kind of be aware that there's obstacles. Not because you're going to walk them into them, but just so they know not to like flail their arms. And then they might ask you to come back into the room to take the person back to them and see where they started. So again, you just reintroduce yourself to them, help them off of the couch and back into the chair that they described before. So yeah, I think that's everything to cover. Do you have any questions about either of those stations?
How are you to know whether like that patient, whether they're or how are you going to
So you can ask them. I would just straight up ask. I understand you have a hearing impairment, how would you prefer I communicate with you? If they really